This lecture is covering nursing care of patients with eye and ear disorders. These are going to be some of the examples of nursing diagnosis we would use. We have disturbed sensory perception, impaired verbal communication, and risk for acute confusion. We could also use some diagnosis from other health patterns such as anxiety and ineffective health maintenance. For health promotion, we're going to be talking about a couple different diagnostic tests. For CT, that's radiologic exam done to identify foreign objects or tumors within the eyeball or the orbit. For your nursing actions on this, you're going to remove any hairpins, clips, or earrings, find out if they have an allergy to iodine or shellfish, and notify the provider if that's the case. And they might give Benadryl or Zantac prior to that and push fluids. The pushing of the fluids will help to remove the dye after the procedure. Refraction retinoscopy. For that, they're going to be measuring the reflective error. If you've had an eye exam, you might notice that the doctor is asking you which one of the images looks better, one or two. That's what they're looking at. And lastly, the tonometry. That's going to measure interocular pressure, and normal IOP is going to be between 18 and 22. Keep in mind, too, that there are some genetic conditions to be aware of. So ask about family history, such as glaucoma or blindness. When you're talking to your patients and asking them questions, ask them if they have any difficulty focusing on objects near or far. Is their vision blurry? Do they wear corrective lenses? Sometimes you're not always going to know this if they're wearing contacts. And do they have any pain in or around the eyes? Pay attention to nonverbal behaviors. Sometimes people like to mask if they're having problems seeing. Again, use of corrective wear, any medications, eye drops included in that, any eye trauma, surgery, or infections. A lot of times if we're doing an MRI on these patients, we're going to ask about eye trauma specifically. Past medical history, family history, and environmental exposure. You probably remember these two from your health assessment class. With the Snellen chart, that's going to be the one with the big E at the top. That is held at 20 feet. You're going to have the patient cover one eye and then the other. This is going to test distant vision. Then the Rosenbaum chart, that's going to be a chart or a newspaper print that's held on a card at a distance of about 12 to 14 inches from the eye, and this is going to test the near vision. With age-related changes, we're going to see a decreased elasticity in the lens, decreased focus and accommodation for near vision. The lens is going to be more stiff and opaque, and yellowing of the lens and changes in the retina are going to affect color perception. This is going to increase the need for corrective lenses. The cornea, fat may be deposited around the periphery and throughout the cornea, and this is going to decrease corneal sensitivity. The fat deposits can also cause some blurred vision. Pupils, they're going to have decreased size and responsiveness to light. The sphincter is going to harden. This creates difficulty seeing in dim light and difficulty seeing at night. This is why we like to make sure that they have lighted pathways at night when they're getting up to go to the bathroom. So night lights are important. The retina visual field narrows and photoreceptors cells are lost. So the rods become less effective. Adaptation to dark and light takes a lot longer. This causes a decrease in peripheral vision, change in depth perception, increasing falls, and a decrease in adaptation to changes in light. Lacrimal apparatus, decreased reabsorption of intraocular fluid, decreased production of tears, and the eyes look and feel dry. The posterior cavity, debris and condensation becomes visible. You might have some issues with pulling away of the retina, and this can cause blurred or distorted vision as well as floaters. So about 3% of the population are going to be classified as legally blind. And some of the more common conditions that are going to be affecting the vision are going to be cataracts, macular degeneration, diabetic retinopathy, and glaucoma. And then with myopathy, that is called nearsightedness. They can't really see something clearly unless it's relatively close to the eyes. So without their glasses on, they're going to have to hold things close. And hyperopathy, that's just the opposite. That's the farsightedness. They have an inability to see clearly if it's too close. So they're able to see pretty far away, like you see in this image. This one's going to most commonly cause impaired vision, and legally blind is classified as an acuity of 20/200. This is going to be conjunctivitis. It's a really severe case of it. So we have an inflammation of the conjunctiva, and it's the most common eye disease. It's transmitted by direct contact. It can be bacterial, viral, or fungal, and it's highly contagious. Acute conjunctivitis or pink eye, that's most often caused by staph. Gonococcal conjunctivitis, that's going to be caused by herpes simplex. That can be caused by direct contact with genital secretions. Think about too with the birth of a baby, and that can lead to corneal perforation, so it can be quite severe. Trachoma, that's a chronic conjunctivitis caused by chlamydia, and that can cause blindness. It's contagious and transmitted by close personal contact. Manifestations of this are going to be redness, itching, scratching, burning. They might feel like they have grit in their eye. They may have photophobia and lots of drainage. Medications for this are going to be usually eye drops or ointment. The most common one I see is going to be gentamicin ointment, but they can also use penicillin, bacitracin, and erythromycin. Erythromycin, a lot of times they will put that in an infant's eyes at birth to treat this in case there's an exposure. Health promotion, education, not sharing makeup, rubbing or scratching the eyes, proper contact lens care, good hand washing, and not sending to school. Sometimes you'll see if nurses have occupational exposure. The example I always think of is like a G-tube. Like if you get G-tube contents in your eye, you're going to end up with conjunctivitis, and you can't go to work for about 24 hours after that because it's that contagious. With cataracts, we're going to have an opacification or a clouding of the lens. This is going to interfere with light transmission to the retina and causes an inability to perceive images clearly. By the age of 80, about half the population is going to be affected. And then more than 1 million cataract removal surgeries are performed annually in the United States. This can cost about $3.4 billion in Medicare dollars. So quite expensive. Most cataracts are formed as a result of the aging process. As the lens ages, its fibers and proteins change and degenerate. These proteins clump together, causing clouding of the lens and reducing light transmission. When only a portion of the lens is affected, it's called immature. The mature cataract is an opacity of the entire lens. And the majority of these are going to be due to the aging process. So this is a memory cue to help you remember the risk factors for cataracts. So it's going to be congenital, aging, toxicity. Think about your exposure to medications as well. Accidents, trauma, radiation, could be sunlight. Also think about tanning or medical radiation like cancer treatment. Altered metabolism such as diabetes, that's going to be the major one, and cigarette smoking or alcohol consumption. Surgical removal is really the only treatment for this, and surgery is going to be done outpatient with local anesthesia. So likely you're not going to see these post-op patients. A lot of times they're done in the eye doctor. Usually the removal is done when the cataracts start to cause secondary conditions such as glaucoma or uveitis. and that's going to be an inflammation of the uvea. If the patient is having bilateral cataracts, surgery is going to generally be done to remove one at a time. And this involves making a small incision, and the lens is either removed in one piece or in several pieces after being broken up using sound waves. The posterior capsule is retained and a replacement or interocular lens is inserted. After the lens is removed, a silicone or acrylic resin interocular lens is then implanted, and this will quickly restore vision and depth perception. Complications for this are pretty rare. They only occur in about 1%, actually less than 1% of the population. So you're going to observe for infection, that's going to be yellow or green drainage, increased redness or pain, decrease in visual acuity, or increased tear production. Provide education to your patients. Instruct them on protecting their eyes from UVB rays while wearing eye protection, and discuss the link between heavy smoking and cataract development. Educate clients to wear eye protection and protect from hazardous activities such as welding and yard work, and encourage annual eye exams, especially in adults over 40. And really with diabetics, they should be having special eye exams. For nursing diagnosis, we have decisional conflict. They want to determine to what extent the cataract is affecting daily life and support concerns. Readiness for enhanced self-management, self-health management, assess factors that interfere with self-care, post-op, and other care needs, such as insulin injections would be a good example. They might need home health or nursing care post-op. Just kind of depends on how much family involvement they have. We call glaucoma the silent thief of vision, and it's the leading cause of blindness worldwide. Oops. With glaucoma, optic neuropathy happens with gradual loss of peripheral vision and increased interocular pressure of the eye. Age and race are going to be your primary risk factors for this. It's going to be most common in the African American and Hispanics over Caucasian population. Your open angle glaucoma is going to be the most common. Of course, the cause of this is going to be unknown. The anterior chamber angle is going to be normal with these patients. Manifestations of this, it's going to be painless with a gradual loss of visual fields, loss of peripheral vision. So the gradual onset of this, sometimes these patients are quite unaware of what's going on, and it's typically going to be detected during a routine vision exam. It's progressive, chronic, and is going to affect both eyes. Closure, that's going to be a lot less common. A narrowing of the anterior chamber occurs because of corneal flattening or bulging of the iris into the anterior chamber. Onset of this is pretty rapid and results in permanent loss of vision, and effects typically going to be one eye. Manifestations include severe eye pain, facial pain, general malaise, vomiting, nausea, seeing colored halos around lights, and abrupt decrease in visual acuity. So some of these tests we're going to see more than once when we're talking about the same section. So we're going to be measuring interocular pressure. We're going to be looking at the fundus, so funduscopy. That's going to be a visual inspection of the optic fundus using an ophthalmoscope. And gonioscopy, that is used to determine if it's open angle from closed angle. So that's how you differentiate between the two. And then visual field testing, that's going to identify the degree of central visual field narrowing and peripheral vision loss. A patient with glaucoma may retain a 20/20 central vision, but be altered in the periphery. When we're looking at medications to treat this, to treat glaucoma, we are looking at a decreased production of aqueous humor and thereby decreasing intraocular pressure. It's not going to be a cure. Androgenic antagonists, these are not going to be for long-term use. They dilate the pupils. You're going to avoid OTC sinus and cold medications because they contain pseudoephedrine, and that's going to accentuate the side effects of this medication. For beta blockers, these do not dilate the pupils. They cause bronchospasm, bradycardia, heart failure. Therefore, they're not good for patients with chronic lung disease, such as asthma. When we're looking at the CAIs, these are going to be used in combination with other medications. They can have a diuretic effect, so instruct the patient to use them in the morning. Prostaglandin analogs, they relax ciliary muscle and allow for more outflow of aqueous humor. They reduce intraocular pressure. They only require a single daily dose. They can cause a darkening of the iris, skin around the eyes, and eyebrows. A trabeculoplasty, that is when a laser burns around the trabecular meshwork of the eye. That's going to cause some burning, and as those scars heal, the tissue causes tension and stretches the angle to allow for aqueous humor drainage. A trabeculectomy, that's a permanent fistula created to drain excess fluid, and that is done under general anesthesia, and the patient's going to be hospitalized after that. Photocoagulation, a laser is going to destroy portions of the ciliary body, and that decreases fluid and intraocular pressure. And the cyclocryotherapy, that is going to be the same thing as above, but it uses cold instead of heat. So they're going to be freezing it with this one. Gonioplasty is going to open that angle. And laser iridotomy, that laser makes small perforations in the iris, which allows drainage from the posterior and anterior chamber of the eye. So this is going to also open the angle. We're going to teach patient to try to avoid coughing after surgery because that's going to increase intraocular pressure. So really, unfortunately, glaucoma cannot really be prevented. So your role as a nurse is going to be education on early screening every 1 to 2 years for patients over the age of 40. And with the diabetics, they really need to be screened yearly. So your risk factors, you want to, with increasing age, African Americans and Asians, and family history. So people with family history of glaucoma. You're going to encourage medications despite the side effects because we want to preserve vision. So with these patients, once they have optic nerve damage, their vision loss cannot be reversed. So we want to prevent that from happening. And the best way to prevent that is to encourage them to take their medications to reduce intraocular pressure. So your nursing interventions are really going to be focused on the loss of visual field. So risk for injury is going to be the big one. Safety is always an issue for patients in the hospital, and decreasing anxiety. So you would want to make sure that you have clear pathways with these patients, let them know where everything is located. I always make a point when I'm taking care of somebody with a visual deficit to get in their room when their food trays get there so I can help prepare the meal, cut it up, and tell them where everything is located. For patients who are blind that are newly blind and are needing help walking, you're going to walk slightly ahead of them and allow the patient to hold your elbow. And just let them know when obstacles are coming up or stairs, things like that. With the retinal detachment, we have a separation of the retina. And this can be caused from a couple different things. It can be from trauma, age, or spontaneous. Sometimes too, I see these happening with diabetics, especially type 1 diabetics. And this is a true medical emergency, so they need treatment immediately to help prevent any permanent loss of vision. Most of the time when these occur, they're spontaneous. Manifestations, these patients are going to have floaters. You see those floaters right there? Lines or flashes of light in the visual field, a sensation of having a curtain. There's no pain with this, and the eye appears normal. They can have progressive deterioration of vision, so these need immediate intervention. Again, this is going to be a medical emergency, and interventions are aimed at bringing the retina back in contact and reestablishing blood flow. Cryotherapy, that is a supercooled probe or laser photocoagulation, and that may be done to seal the retina holes and create an area of inflammation and adhesion to weld the two areas together. Scleral buckling, that is a surgical procedure, and a fold is created in the sclera, and that brings the retina back in contact, and a buckle or a strap holds it together. This is usually going to be the most effective type of treatment for patients. And then pneumatic retinopexy, that's when air is injected into the cavity and the body is positioned so that the air bubble pushes the detached portion of the retina back in contact. Nursing diagnosis, ineffective tissue perfusion related to the retina, they're going to have some anxiety. This is kind of a scary thing that happens. So you want to make sure that you're carefully assessing anybody who complains of sudden and rapid loss of vision, because that's going to be a medical emergency. Moving on to the ear, we've got some diagnostic testing that can be done to assess hearing. This one here, the audiometry, that's when the patient sits in a soundproof room and they raise their hand when a sound is heard. This diagnoses conductive as well as other types of hearing loss. Sometimes with these two, they'll hit a button instead of raising their hand. Auditory evoked potential, that's also called an AEP, that identifies electrical activity of the auditory nerve. They will place electrodes on various portions of the ear and the forehead, and it records a graph. Auditory brainstem response, ABR, that measures electrical activity of the auditory pathway from the inner ear to the brain, and that diagnoses brainstem pathology, strokes, and acoustic neuromas. The caloric test, that assesses vestibular function, and this is when cold or warm water is used to irrigate the ear canals one at a time. The patient is then going to be observed for nystagmus, and remember that's the abnormal movements of the eye. And if no nystagmus occurs, they will need further testing, because usually this occurs opposite of the ear being irrigated. So if they're irrigating the left ear, the nystagmus is going to occur on the right side. The Rhine test, that's when you're placing your tuning fork on the mastoid bone, and when it's no longer heard, when the patient no longer hears the sound, you move it in front of the ear, and that tests for conductive hearing loss. The Weber test, that's when you're placing the tuning fork on top of the head to see if the patient hears it equally in both ears, and that is assessing for conductive hearing loss as well. And then lastly, we have this one that looks for Meniere's disease of the ear. And with Meniere's disease, they're going to show an increased pressure in the ear with this. So when you're talking with your patient, ask them if they have any difficulty hearing high or low pitched sounds. Ask them about tinnitus. Do they have any ringing in their ears? Monitor nonverbal behaviors again. A lot of times people will try to cover up or hide that they're having hearing difficulties. Assess past medical history, exposure to loud noises, medications, and family history. I'm not sure if this page number is going to be correct for you, just because the PowerPoints and the books have changed. Presbycusis, that's going to be your progressive hearing loss. They're going to have an inability to hear high-pitched frequency sounds. And degeneration and atrophy of the vestibular structures. They're also going to have an increase in cerumen in the ear canal. Vertigo, that's going to be a disorder of equilibrium, and that's going to be a sensation of movement when there is none. And that's a hallmark manifestation of inner ear disorders. When you're questioning your patients about dizziness, you would need to ask them if the room is spinning or if they feel like they're spinning. Labyrinthitis, that's a rare inflammation of the inner ear, and the manifestations of that are going to be nausea and vomiting, nystagmus again, pallor, sweating, hearing deficits, and vertigo. Meniere's disease is a chronic disorder characterized by recurrent attacks of vertigo and tinnitus and a progressive unilateral hearing loss. This is going to result from an excess of endolymph, and that's the fluid in the inner ear causing excessive pressure. Sometimes there's certain activities that will increase stimulation, like reading or even watching TV. In addition to vertigo and tinnitus, these patients can also experience a fullness in the ear and eventual hearing loss. And again, that's going to be unilaterally. Diuretics are going to be used in Meniere's disease to reduce pressure. CNS depressants may halt an attack of vertigo. Sedatives, that's going to cause an antiemetic effect if nausea is a side effect. And antiemetics are used to reduce the whirling sensation and nausea. Gentamicin, if they're having an infection, that can be used to treat inner ear infections. And avoid moving the head suddenly. This will increase vertigo. Usually what I tell patients is to kind of move their whole body slowly, so instead of turning their head quickly. And then low sodium diet, that's going to decrease water retention. And then of course health promotion. So safety is always going to be a risk with vertigo. Provide a quiet, darkened room if they're having an attack. Prevention of future attacks, so you want to preserve the hearing, again, low sodium diet, and then avoid smoking, alcohol, and caffeine. An acoustic neuroma, that's a benign tumor that's going to compress the auditory nerve. These are common, occurring in about 1 in 100,000 people annually. The inferior cerebral artery is going to supply the pons, the medulla, and the brainstem, as well as the cerebellum of the brain. So when this is going to be compressed, it's going to cause neurological signs. So be aware of that. You're going to be assessing your patient for vertigo, dizziness, nystagmus, unilateral hearing loss, as well as tinnitus. Treatment of choice, they're going to want to excise this tumor if possible, so they're going to want to remove it. And microsurgical techniques can be used for small tumors, and this is going to really save the hearing. So here we've got an approach that provides good access to the tumor and allows for facial nerve to be preserved, but this can destroy hearing on the affected side. And a craniotomy can be done, and that can result in facial nerve paralysis. So your post-op care, you're going to minimize cerebral edema, monitor for signs of increased intracranial pressure, assess speech and swallowing before allowing the patients to eat, consult with speech therapy, and provide lots of education to these patients. With hearing loss, we're looking at partial or total, congenital or acquired. So these patients can be born that way or they can acquire it. A friend of mine has a daughter that's hearing impaired, and she was born with her hearing intact, but medications she was given shortly after her birth made her lose her hearing. So that would be acquired. and they can lose all or just some of their frequencies. Risk factors are age, genetics, and lesions. And patients that are unaware of their own hearing loss are they're going to speak louder. So they're going to have an increase in voice volume. They might position their head so that their good ear is towards the speaker. They're going to ask questions over and over again. So they're going to say, huh, or ask the speaker to repeat that. And then they're going to be responding inappropriately. So it's best to use a low-pitched tones with these patients. You'll hear some families say you need to speak directly in the left ear. Sometimes if you just lower your pitch a little bit, they'll hear you better. So we have a couple different types of hearing loss here. So we're looking at conductive, anything that's going to be disrupting the transmission of sound from the meatus to the inner ear. There's going to be an equal loss of hearing on all frequencies. So this could be caused by obstruction of the ear canal. So I want you to think about earwax, edema, even neoplasms. With sensory issues with hearing loss, these are going to be caused by loss or damage to the receptor cells. They're going to have a decreased or distorted ability to receive and interpret stimulus. This can be damage to hair cells, a tumor, vascular disorders, infections, trauma, or even degenerative diseases. Presbycusis. So with aging, the hair cells degenerate, and this produces a progressive sensory hearing loss. Hearing loss that makes speech discrimination difficult, especially if it's a noisy environment. Hearing aids usually are not helpful with these because they magnify both speech and background noise. Sometimes with these patients, if they're in the hospital, we have these little hearing amplifiers that look like headphones. This one looks like a Bluetooth, but they look like headphones, and we'll give them that, and that can be helpful to them. Treatments for this, they might perform a stapedectomy, and that's a surgical procedure in which the innermost bone of the ear is removed. And then they can also repair the eardrum if the damage is occurred there. Cochlear implants, that's what my friend's daughter has, and that consists of a microphone, a speech processor, a transmitter, and electrodes. They provide sound perception, but not normal hearing. Tinnitus, this is going to be a perception of sound or noise in the ears without any stimulus in the environment. Drugs that can cause this are salicylate, quinolone, Lasix, so furosemide. That's why we want to be careful with how fast we're pushing that medication. This can be a buzzing, a roaring, or a ringing, and this is often an early symptom of hearing damage and drug-related ototoxicity. These can interfere with ADLs. This is something that I have it constantly in my left ear, and it just kind of makes a high-pitched ring noise. It's more annoying in quiet environments, I've noticed. So if you have a patient that's really suffering from this, the more quiet it is in the room, the louder the tinnitus gets. So if you give them some white noise, so I usually have white noise in the background or running water, that also helps to kind of drown that out. And everybody's tinnitus is a little bit different. So what works for one person may not work for the other. Health promotion, we want to educate our patients on using ear protection around loud noises, especially, I hate to pick on the guys, but men tend to have jobs that are around more mechanical things, so they really need to be wearing ear protection. Proper care of ear and ear canals, not placing hard objects in there. I see people all the time sticking bobby pins in their ear to scratch it, so we in the hospital they do that. We need to take those bobby pins away from them. Earplugs while they're swimming, and then side effects of ototoxic medications. That's really something that you need to be aware of as a nurse, especially if you're pushing things like Lasix. And then prompt intervention when there's hearing difficulties. And then our nursing diagnosis, they can have risk for trauma. Think about if they're not able to hear, they might not react to loud noises appropriately. Disturbed sleep pattern, think about that tinnitus. It can get kind of annoying when you're trying to sleep. disturbed sensory perception, impaired verbal communication, and then social isolation. A lot of times these patients, they don't want to speak up and say they can't hear you. They get embarrassed, so they'll just not say anything, and they have no idea what people are saying around them. Okay, well, this wraps up this section. You have a great night.